I asked not to stand behind this piece of furniture here. First of all, good afternoon. This piece of furniture, because height-wise, it poses serious competition. So if you, as I'm standing here, if you find my neck or you see as if I'm pulled this way, it's because there's a foreign object here that is tugging on my ear. But as I stand here, I stand at a vantage point. I can actually see the splendor of the conference because a conference is the people. And that's why I would like to salute the organizers for this dignified conference, friends and colleagues under one roof with a common purpose. And I would like to also congratulate you on your anniversary, your celebration. And I feel honored to have been invited to partake. Now, my topic is on, something is happening here. My topic is on pain. Now, this is the commonest reason why people would go and seek medical help. And if that pain becomes chronic, according to studies, those people who have chronic pain, they are 5 times more likely to go and approach or rather consult for help. Now we're talking about a phenomenon that can be a minor irritant, but it can strike with a disempowering ferocity most profound. Let's go to my friend now. This is, he's become my friend. Let's imagine you had a friend visiting our planet from some faraway planet, let's say Pluto. I call him Z, because I don't have I would have given him a long name. Let's say Z is here and you are taking him around and you say, Z, this is how we look. We've got 2 eyes. We look like this. And, and one of the questions he asks is, tell me, my friend, what is pain? Okay, in any case, I'll just continue talking. Let's say Z asks a question, tell me, my friend, what is pain? You pinch this guy, you stamp him, hard on his, feet, and he looks at you blankly because he does not have nociceptors. Now, these nociceptors are those receptors which help us to appreciate pain. So, in other words, what Z needs from you is to define this which we call pain in words. There's something that I would have liked to show you now here. But in any case, there is the definition by the International Society for Pain goes thus, that pain is a subjective, unpleasant feeling. You're telling Z now, explaining to him. It's an unpleasant feeling, Z, or sensation that signifies impending or actual tissue damage. So, in other words, Z, what we mean by what must I do now? Okay, that sign means that Z comes in peace, okay? So, you say that this pain signifies, or it's a sensation that signifies impending or actual tissue damage. So in other words, this pain is our alarm system. It is something that tells us that something is wrong. Now this is important because if your alarm goes off in your house, you don't just switch it off and go back to sleep. That wouldn't be an intelligent move. You would want to go and see. You could switch off the alarm, but you want to know what made it to go off to start off with. So to give analgesics and pile, trying to stop the pain, it is important, but you still want to know what made that pain to happen, or that alarm to go off. Now, before this definition that I just narrated to you, there was an earlier description or a definition of pain. whatever the experiencing person says and whenever. Now, that is a vague kind of statement, one could say. Whatever the person says and whenever. So what that statement is actually saying is that the alpha and the omega of pain is truly subjective. So in other words, when someone says, I feel pain, it is not for us to second guess that person. So you have to take, sometimes what we do is we would give an imaginary scale between 0 and 10, how much is your pain? And if the person says, it is 10, it is not for us to say, nah, is it not 4 maybe? If it is 10 for that person, it is 10 for that person, right? I'm going to go now to this alarm situation. I've already explained to that it is our alarm system, and that is why if someone has diabetes, for example, with their numbness of the feet, you don't want those people to walk, to walk barefoot outside because the alarm is not working properly. They can injure themselves, they can get infections as a result of not being able to appreciate pain. But then that definition goes on to say that even if there is no impending or actual tissue damage, we express pain in terms of tissue damage. If I were to say, she broke my heart, it tore me apart. What I'm saying is, I am in pain here, So, what we are talking about when we are referring to pain, not only are we referring to the physical, but we're also referring to the emotional. And the perception of pain, in fact, is not only cortical, it is also perceived in the limbic system. Now, for us to understand this pain further, we divide it into nociceptive and neuropathic pain. Maybe I'm preaching to the converted, I'm sorry about that. But basically, this is to say that pain is not one monolithic group of conditions. There are different mechanisms underlying this which we call pain, right? And when we speak nociceptive, it is the type of pain that is dependent on inflammation. And this now has got immediate and direct relevance as to how we're going to manage that pain. So if you're going to direct your management on inflammation, then you're going to be successful. Unlike this one, which is neuropathic. Now that is not dependent on inflammation, and in fact you'll find that anti-inflammatories are not going to produce the goods now. Further, to subdivide that nociceptive, it would be somatic, that it is well localized, and then you can have the so-called visceral pain, which is poorly it tends to be colicky, a kind of deep pain. You can't point exactly where the problem is. That is visceral, still under nociceptive. Neuropathic, you can have peripheral and neuropathic pain. We're going to go a bit deeper into this a little bit, and you can have it being central. Now, again, under nociceptive pain, the character of the pain, here's something that is important, or I find important, is nociceptive pain has got a short history. Now, when you speak of when the pain becomes chronic, it is something that, or rather, let me say, nociceptive pain can actually morph into neuropathic pain, right? And this is oftentimes chronic. We're going to talk about that as well. And the character of the pain is not quite the same. A patient who presents with pins and needles or a burning sensation, this is the kind of pain that we would expect from neuropathic mechanisms, right? And there would be a poor response, as we've said, to conventional analgesics here, unlike with nociceptive pain. Nociceptive pain, here are examples here: arthritis, that itis being inflammation, post-operative pain, injuries, etc. Now, here's something, maybe to just narrate or to emphasize or re-emphasize something that I've said. I remember being phoned by someone. I was in Durban. She called me about a friend of hers who had been discharged that very same morning. This is the afternoon. And this friend was not responding to analgesics. She had been admitted for a cesarean section. She asked me, what can we use for the pain? she's on paracetamol, she's on an anti-inflammatory. What is it that we can use for the pain? And I asked her a question, is she pale? And she said, how do you see if someone is pale? I said, look at the tongue. And she looked at the tongue and she said, it is white, white. I said, take her back to hospital. And she was taken back to hospital only to find that she was bleeding inside. There was some kind of dehiscence, and this actually would re-emphasize that which we've already discussed, that in fact pain is our alarm system. If I had said, okay, let's give more and more analgesics, that friend of hers would today be safely underground. Neuropathic pain, right? That is now an example. I'm going to show you a CT scan of what kind of stroke can cause pain, right? You've got other types of pain, and the mechanism we're going to talk about later. Now, that is one of the common conditions that we see. There was an article from Atlanta, Georgia, and the article was published in Neurology, and the title was, How Common Are the So-Called Common Neurological Conditions? And common, chronic headaches are quite common. And in my department, let me think, headaches they come number 2 now. In our database, we've got about 2,000 or so of patients who present with chronic headaches. So we're talking of something here that is quite common. And that which makes us say a patient has a headache is when the pain is in V1, what we would call the ophthalmic division of the trigeminal cervical to dermatome and to the neck. That would be now a headache. Now, the reason why I'm showing this slide here is to remind me that we don't always use the conventional analgesics, anti-inflammatories, Panados, etc. We use prophylaxis for the chronic kind of pains like a chronic headache, like migraine, like tension-type headaches. And that would include things like a beta blocker. Obviously one has to be aware of the contraindications thereof. Something like a tricyclic antidepressant, one has to know what contraindications there would be before one prescribes anything. Now, this tricyclic antidepressant, if you were to give someone who is on an anti-Parkinsonian treatment, I'm thinking now of something like selegiline. Now, selegiline is a monoamine oxidase inhibitor, and if you were to combine it with a tricyclic, you would be inviting bad news. Now, I remember one patient who had a headache that was not responding well to treatment, and he comes to me, this is chronic, and he says, Doc, the only thing that helps for me is marijuana. What do you think? Do you think I should continue with them? I don't know what the audience would say to that situation. Right, I'm going to leave headaches. Now, you have, if you remember, I said that the headache starts from if the pain is here in the forehead all the way to the neck. But now, if the pain is below, then you'd speak of facial pain. And a common one would be trigeminal neuralgias. And this now is a type of neuropathic pain. It is a lancinating type of pain. Even touch actually makes one to have or triggers the pain. Now, the type of pain that this person is having is not going to respond to anti-inflammatories. It's a type of pain that we would use membrane stabilizers for. Right, we're going to talk more about that. So you have different types of neuralgias. Sometimes you have a patient who presents with a neuralgia on swallowing, and that would be the so-called glossopharyngeal neuralgia. And on swallowing, they may even have syncopal attacks. In other words, they may faint, fall to the ground as a result of that pain, which is so profound. The management is the same. Now, a cause or a reason why someone could have this kind of thing, it has been found most of the times that there is a vascular loop, a vessel, that is irritating the nerve, right? And sometimes, if these people don't respond to medication, you have a small surgical procedure that is going to alleviate that situation. Now, peripheral neuropathies can be very painful. You know, I remember a patient who was unable to walk upright. He was crawling on his knees. The skin over his knees, you know, would have made one think he's very religious. You know, it was because of allodynia, hyperpathia, and these are things that a peripheral neuropathy can present with. You know, in Shakespeare's Macbeth, you know, there's a king there, his name is King Duncan. King Duncan has a son by the name Malcolm. Now, Malcolm is told by another character in the play called Macduff. He says about Malcolm's deceased mother, your mother was often more on her knees in prayer than standing upright. So in that situation, it was for religious reasons, but pain is something that can cause one to crawl on the knees. Now, if one was following the Truth and Reconciliation for the people, for the visitors, people who come from abroad, from neighboring countries. Here in South Africa, at the end of apartheid, we had a reconciliation process, you know, and one of the narratives in that, in those proceedings, there was a story of a young student activist. His surname was Mtimkulu. I forget his name, Siabong, I think. Mtimkulu. But this gentleman was in prison, and he started having a lot of pain, and no one could understand what is going on with this guy. And he was then taken to Grooteskier in Cape Town, and the professor or the head of neurology at the time was Professor Francis Ames. It's only when he started losing hair that the head of department thought he must be getting thallium. And in fact, it was the truth. The police were giving him this thallium, and the nice thing about this thallium, I'm saying nice in the negative sense, that thallium is it doesn't have an odor, it is tasteless, and you can lace it nicely on food, and you can continue enjoying your Kentucky Fried Chicken or whatever it is that you enjoy eating. And it causes a profound pain, and this is a neuropathic kind of thing. So what I am trying to say here is that the ferocity of pain can be so profound that even your enemies can consider using it against you. Now, this is a CT scan with a small lesion right here. This is an infarct, right? Infarcts usually cause strokes, but if the infarct is very small, like in someone with hypertension or diabetes, it can cause that which we call a lacunar infarct. So it is a very small, less than 2 centimeters. But now, this infarct is strategically placed. It is in the thalamus. And this now causes a kind of pain that is central and neuropathic. The one side becomes very painful, but at the same time, you find that the patient has got decreased sensation on the very same side that is painful, and that is called anesthesia dolorosa. Now, the syndrome that this infarct would cause would be the so-called Dejerin-Rousey. Not easy to manage. This is not a pain that is going to respond to anti-inflammatories. We're going to look at some options going forward. Now, I remember a patient as well, speaking of central neuropathic pain, a patient with Parkinson's disease, paralysis agitans, slow, tremors, they turn around. You know, my daughter this morning told me, you know, when my teacher pushes me, I start having a bit of a tremor, you know, and it's called Parkinson's. So I started laughing, and she said, what are you laughing at? I researched it. But in any case, one of the non-motor manifestations of Parkinson's is pain. And that pain responds not to anti-inflammatories, not to the conventional things that we use for neuropathic pain, it responds to levodopa. Right, this is just a cartoon to show the basically the factors that are going to result eventually to pain. That this is something that is going to be with the nociceptors are going to transmit that information to the dorsal root. So the dorsum is posterior, dorsal and ventral is anterior. This is law according to, or it is the so-called Bell-Magendie law. Now, the Bell-Magendie law tells us that that which is sensory is going to be transmitted dorsally, and that which is motor is going to be transmitted ventrally. Right? I'm going to just move on. The person who linked inflammation to pain did us a favor. Now, here's something else. The gate control theory. I don't know if I'm going too fast or too slow or talking too much, but I'm going to try. The gate control theory, this is a theory that was first described, I think it was in the 60s, where it was shown that non-noxious stimuli compete with noxious stimuli. So something that is going to cause pain is transmitted via small fibers, and things like touch are going to be transmitted via large fibers. So when you have this competition, you find that the non-noxious stimuli can actually dampen your perception of pain. And this is why when a child falls and injures himself or herself a bit, the mother rubs there. It is to activate that mechanism. As a registrar, I used to be excited about that which we call the action potential. There would be no life without the action potential. The reason why you can hear me speak, it is because the words that come from me are changed in your nerves, the cochlear nerves, and they are changed into electricity. And this is called transduction. The fact or the reason why I can see you or you can see me, again, it is the same action potential that is helping us. The reason why we can feel touch, we can feel pain, it is because of the action potential. And I remember saying to my colleagues, guys, if we can understand this action potential and manage it, I think we've solved medicine. Okay, but in any case, this action potential is that which is going to help the transmission of impulses, whether these impulses are going up, whether they are going down. For me to move, I need that action potential. And if we understand that electrolytes, there are certain gates that close and open for this action potential to continue and for this action potential to initiate other action potentials, then one can go a long way in the management thereof. I'm going to leave this. Or maybe before I continue, that sodium, when we test blood, the sodium, the normal values of sodium is 135 to 145 millimoles per liter. And when you look at potassium, on the other hand, is between 3.5, 3.4 to 6.1. So there's a difference. And the reason why there is such a difference, it is because this sodium is mostly extracellular and the potassium is mostly intracellular. And that which maintains the order is an energy-dependent pump. It is not an energy-dependent pump to maintain that order. And if we didn't have that energy, ATP, we wouldn't be sitting here. Because anything would be going any which direction, would be having cerebral edema, we wouldn't be having this conference. Right? This, I think we can skip. I just want to show you a sea of numbers. This is what we do, when you want to look a bit clever, you show But basically, this is an EMG. When we test the peripheral nervous system, we do these kind of things. And don't worry about a lot of these numbers. Just have a look at this. That CV stands for conduction velocities. And look at, for example, this median. Look at that median. It conducts normally at more than 50 meters per second. A meter is something like this. This is my arm. Imagine 50 of these arms in a second. So this is very fast, and this is something that is protective, obviously. So if I touch something that is hot, that which is going to help me to appreciate the pain is going to transmit via that action potential very fast. Now, I'm almost through, Prof. I hope you're not panicking. Right? Now, that definition of pain, when we were explaining it to Zed, we said it's an unpleasant sensation. Now, there are people who are going to walk around on hot clay, on hot coals, and I think they are actually challenging the notion that pain is always unpleasant. Look at this guy, he's having a nice time. There are certain sexual practices, sadomasochism. I don't know if one would say, these are people who are going to endure or expose themselves to pain for pleasure. And I don't know whether one would say that is a psychiatric situation because these people are otherwise okay. So now the notion of saying pain is necessarily unpleasant, I don't know. Maybe it's something that this conference at one point could talk about. Okay, factors influencing pain perception, there are individual variations. I'm not going to go through all of these situational factors, like the gentleman walks on coal because it's a situation where everyone has to do it, peer pressure. I don't know whether it's peer pressure, but culture, etc., emotion, I am angry, or there's an emotional overlay. Am I going to experience pain the same as when I'm otherwise not so emotional, right? I'm just going to go through this. Now, I spoke of transduction. Now, this transduction is a change in energy. Whether it is noxious, whether it is a thermal thing, this changes to electricity, and that is transduction. And then you have transmission. You remember we said at more than 50 meters per second, and it goes up to the cortex and to the limbic system, so there's emotion here, and that is now perception. Now, beyond that, there's modulation. Now, modulation of this which we have to perceive, are we going to dampen it? So there are certain mechanisms within our body, naturally even before we start with the medications. But I took this slide, it might not show so nicely, as to where certain drugs that we use work. For example, the anti-inflammatories would work on the prostaglandin synthesis via the COX pathway, and things like carbamazepine that we would use for that trigeminal neuralgia would be working at those sodium channels which are important for that action potential and the transmission, and it goes on and on. Let me leave this. Mechanisms, again, this is just basically to say that there are different sites of action for the drugs that we give, and one has to be very clear about which type of pain one is dealing with. I'm almost through. The comorbidities become big when pain is chronic, right? And there's a triad here. On top of the pain, one has to look into things like sleep disturbances, which can accompany chronic pain. Anxiety and depression are a big thing when pain is chronic, and they, on their own accord, ought to be managed. And the management of these non-pharmacological, there's a whole lot of things before one can give, or rather, medication is not the only thing that could be an answer to, especially if the pain is chronic. I remember one patient at Tabatswane, this is one military hospital, who had been having a lot of headaches chronically, and just looking at the lifestyle on top of the medication that she was getting, she actually improved. And the next visit, she said, "Where were you all my life?" Man, I would never forget that kind of expression. Where were you all my life? I didn't give anything different. I explained how things go. This is how you should manage things. Let us not be too dependent on medication. Now, you would think that because we understand, or we think we understand this mechanism behind pain, that everyone would actually be okay. But we still have a big problem with pain being undertreated. And that is why when Prof. Duploy says, "Dali, come and speak on pain," this is not a wasted exercise, right? Now, I'm quoting that landmark study of 1,300 patients, just over that, who 42% of them, of those who needed pain management, were insufficiently managed. Now, there are various causes here. You know, this list is not complete. I couldn't go on and on and on, right? For example, an under-assessment. We said that pain is completely subjective and one must not second guess the patient. And if one does, you run the risk of undertreating. There's a whole lot of other things like cost. That patient who said, why can't I use my marijuana? I don't know what to say to that kind of thing, because he says, in fact, the marijuana switches the pain off. The cost, this is something that you'll all know about. Not only are we looking at direct cost, the investigation of that which caused the pain and loss of productivity. These are all important things that, sort of place a cost burden on society. This is my last slide. I want to tell you about the Roman Emperor Julius Caesar. Now, this is a guy who was in power for 5 years, and in today's political language, would say it was one term. But history continues to remember him as someone who was very brave. This is, as a young man, he crossed a river called the Rubicon. Now, when you cross that river, this is not a big river, but there was a significance in crossing that river, because it meant that you were challenging the incumbent, and the incumbent at the time was Pompey. So he crossed with his forces that a small river called the Rubicon, and Pompey knew that this young guy is now declaring, or wants a fight. And there was a battle, and Pompey, the incumbent, was defeated, and he fled. And Julius Caesar chased him all over Europe, and he found him in Egypt, Prof. He found him in Egypt. And the Egyptians, the ancient Egyptians, as a token of friendship, gave him Pompey's head. Right, so Julius Caesar arrives in Egypt, Pompey was there, and so they give him Pompey's head. They kill Pompey, they give him his head, so as to say, we are friends. And now, mission accomplished, he then focused his romantic attention on Pompey's erstwhile girlfriend, Cleopatra. Now, this brave man, he makes a statement. He says that he has seen many a young man who would gladly die than endure pain patiently. So in other words, he is saying pain is something that is worse than death. In other words, he's saying pain is something that was respected and will continue to be respected as it is today, and I think forever. I'm going to stop here. Thank you.